and then also after menopause occurs. 1 in every 3 women in the United States have some sort of pelvic floor disorder. And we'll talk about each one specifically after, but this is a huge number, right? This is when, if you're walking down the street, every third person you will pass will have either prolapse, incontinence of some sort, overactive bladder, or your current urinary tract infections. And these are also things that many of us do not talk about, right? We oftentimes will talk about our heart, or talk about our diabetes, talk about the headache that we had. These are all things that are very, set and core about our health issues. And we talk about them with our friends, with our family, but very rarely do I find people are open to talk about these things with the people around them. So what happens is that a lot of the information and education that's out there is very minimal. So most women don't know that these are things that don't have to occur, or if they do occur, there are treatments and solutions for them. And oftentimes the treatment and solutions don't have to be surgery. They can be very minimal conservative things that one can start at home. So let's talk about prolapse first. And you'll see at the bottom of the screen, there's going to be a picture of one of the 3 different providers, one of the 4 different providers I work with. So you'll see them throughout. So first is prolapse. And prolapse is something that, most women don't even know is an entity that can occur. Essentially, it's a hernia that occurs in the vagina. So it's a bulge or pressure or mass that many women feel within the pelvis as the day progresses. It's essentially this heaviness, this feeling of pressure that as you're walking, as you're lifting something heavy, starts occurring in the bottom of your pelvis. Why does it happen? Well, the pelvic floor muscles and ligaments start to weaken and get stretched. This can happen oftentimes after having vaginal deliveries, having pregnancy in general, lifting anything heavy, having chronic cough, chronic constipation, or even, just as we age, it can happen to us too. Just like our muscles on our face and everywhere else, as time goes down, gravity takes a hold and, we'll have some of the drooping here. We have drooping in the vagina as well. The only thing is that not everyone feels it. Half of our patients do feel it, and they're the ones who come in because they want to have some treatment for it. There are half of women who don't feel prolapse at all and can go about their days without any issue. For them, they don't have to do anything because prolapse is not life-threatening, it's not dangerous, and it won't change your health. The only times we have to do treatment is 1, if it bothers you, 2, if it causes changes in your urination or your bowel movements too. And sometimes as the prolapse gets worse and worse, we see a bulge protruding through the vagina. And that's something that you can feel yourself when you're wiping, or that when you go to the doctor's office that they see as well when they're doing an examination. Once again, if this doesn't bother you, it doesn't have to be treated. If it does bother you, if you feel it, if it's causing irritation, if it's causing you any type of frustration, then you can come in for treatment. And treatments range from many things. So first, let's kind of talk about what the pelvis is normally and what prolapse looks like too. So this right here is a picture of a woman from the side. So if I took someone and just look at them right on the side of their body. In the front here is a pubic symphysis, which is that bone right in the front of your bladder that you can feel right if you touch directly on top of your bladder. Then after the pubic symphysis, that's where your bladder sits with the urethra coming down. Then there's your vagina here. That at the very top of the vagina is the cervix and the uterus, which is the womb. And then behind the vagina, we have the anus that's connected to the rectum. This right here is a picture of someone that does not have any prolapse. If you look at their vagina, everything is supported up. The walls that are here, here, and here are still upwards and they're not causing any prolapse to occur. Sometimes the wall here against the bladder, or the wall here against the anus, or the wall here between the cervix and the uterus can come down. Let me show you a picture of each one of those. So this right here is when the bladder wall prolapses on the vagina, right? So comparing to this picture above and this picture now, you can see what a difference this is. Now you have this bulge that's coming down on the front portion of the vagina. Oftentimes you feel it as pressure as your day progresses, as well as your bladder fills. Imagine this bladder getting full of fluid. When it gets full of fluid, you'll feel even a bigger bulge here. So sometimes you may not feel it until your bladder is actually full too. This is what we call a cystocele, or anterior vaginal prolapse. Many women actually have this. This is one of the most common types of prolapse. Another type of prolapse is something called uterine prolapse. And this is what most of my patients come in and tell me. They're like, hey doc, I think my uterus is falling out, or my cervix is falling out. I feel something hard in the vagina. When I touch it, it feels like it's firm. And this is oftentimes what's going on.
Are there any pictures? I don't see any pictures. Are there pictures being shown?
Yes, there are. Can everyone see my screen? Margie, can you see my?
I see you, but no pictures that are you showing us?
Yeah, this is let me see. Margie, can you see my my PowerPoint or no?
I see it.
Okay. So
We can see it too.
We can see it. We can see it.
I see it.
thank you, everyone. So I think the person who can't see it, there should usually be two toggles. There's one box that has a picture of me that might be very small for some people on the side, and then my presentation's big. And then for you, maybe the picture of me is rather large, and then the presentation's really small on the side. If you click on that presentation on the side, the really small figure, that might make that bigger for you. Hopefully that works. And so and I will send this presentation at the end of the talk too. So for anyone who can't see it, then you can see it as well then too. So as I was saying, the uterus and the vagina coming downwards is called uterine prolapse here. So compared to this picture here, where the cervix and uterus are high up in the vagina, this next picture, you can see the cervix and the uterus are almost involuted coming down, and you can actually even feel it at the entrance of the vagina here. So this is uterine prolapse, also incredibly common too. And then the last type of prolapse is rectal prolapse. So essentially it's the rectocele, which is the wall between the vagina and the rectum. And compared to this picture here, where you can see that the rectum is well supported, here you can see there's a bulge here. Just like with the cystocele, or when the bladder was coming down and you felt that in the vagina, you can feel this in the vagina as well. Oftentimes more so when you're having a full bowel movement. After a bowel movement, you might have a resolution of some of your symptoms as well, but oftentimes not a complete resolution. So that's prolapse. That's prolapse in the anterior vaginal wall, the apical one where the uterus and cervix lay, and then the back wall where the rectum is as well. It happens to 1 out of 3 women. Half of women don't feel it, half of women do. The women that do feel it, are bothered by it, or have changes in their urination or bowel issues, come in to see someone like myself for treatment. Treatment can be a range of things. Like I said, if you don't feel it, you don't have to do anything. But if you do feel it, we talk about conservative measures. So if it is, hey, it only happens when you have a full bowel movement and you're not having bowel movements for 5 days at a time, then maybe all we have to do is, make your bowel regimen be a little bit better for you. Maximize the amount of your fiber intake, maybe add some prunes, do different things to make it so you're not quite feeling it that much. As we go over conservative measures, what is really important for us is figuring out what your daily life is like. What makes sense for you in terms of, yes, I can actually maybe take a walk during the day, help with my bowel movements, or maybe I can go to the bathroom at these times. And that makes sense for what I'm doing right now, for my work, for my life at home, and for what I do outside the house too. So we go through very specific conservative measures that are kind of tailored for your life in terms of what we can do to treat that. If that doesn't work, or if your prolapse is a little bit more advanced, we talk about these 3 treatments here. Pelvic floor physical therapy, a pessary, which is a picture of it right here, or surgery. So pelvic floor physical therapy. I think most of you have probably heard of Kegels. And we've, especially after having vaginal deliveries or childbirth, a lot of GYNs talk to their patients about, hey, make sure you do some Kegels to decrease your chance of incontinence and prolapse as time goes on to strengthen the pelvic floor. But no one ever actually teaches you how to do one, right? So it's kind of this, blanket statement, go home, do some Kegels. And some of us try to look it up. and we try to do it. And although that is beneficial compared to not doing any, there's actually licensed, trained pelvic floor physical therapists that, just like if you would go to one once you got your back out or had an arm injury, that teach you how to do these exercises correctly, and they do them in the office with you. They're incredibly helpful. If you go to a pelvic floor physical therapist compared to just doing Kegels at home, your chance of actually treating your prolapse successfully goes up exponentially. So it's one of those things where I'm like, hey, if you can do it at home, wonderful. But if you can't, there are licensed providers who can teach you how to do this appropriately. And all you need is a referral from us, and we give you some names of where to go. You can go from there. If your prolapse is a little bit more, severe than what pelvic floor physical therapy can treat, we talk about pessary or surgeries. Pessaries and surgeries are essentially equivalent in terms of how well they work for our patients. And we talk about each one very specifically, once again, based on what makes sense for your life. What do you actually want to do? What do you like to do? Pessary looks like this right here. Similar to a diaphragm, if you've ever used one of those in the past. It's a bendable device. We fit you for it in the office. We figure out the right size. There's over 18 different types of pessaries, multiple different sizes. Once we fit you for one in the office, we teach you how to put it in and take it out. As long as you don't have a lot of arthritis in your hands, most patients are able to do that successfully themselves. And you're able to place that in the vagina, and you won't feel the prolapse, and the perfect pessary, you won't feel the pessary either. And, for some women, that works really well, especially for women who have cardiac or lung issues where surgery is really not an option for them. But for some women, they say, hey, I actually want a fix that's a little bit more permanent, or, I can't see myself putting something in and out of my vagina, as the days go on, especially as the years go on. Can we do something else that's a little bit more permanent for this? And then we start talking about surgery. Surgery for prolapse now is very different from surgery from prolapse 10 years ago. So if you've gone to a provider in the past and they talk to you about surgical options, the ones now are very different. Over 92% of my patients go home the same day of surgery. We do essentially outpatient surgery because everything we do now is very minimally invasive. We've stopped doing those large incisions on the abdomen. We do everything either vaginally, which is like a natural orifice that allows us to do surgery through, or we do it what we call laparoscopically, where we make incisions smaller than my pinky on the abdomen and do the surgery through that. If you live far away, if you have other medical issues, then yes, maybe we would like to keep you for a night in the hospital just to make sure that you're doing well. But most of my patients go home and sleep well, and I give them a call the next day, and they're very happy too. So those are treatment options for prolapse. You don't have to do anything if you're not feeling it. If you are feeling it, we kind of tailor conservative measures for you. We talk about pelvic floor physical therapy if it's mild, and then if it's more severe, we go through either a pessary or surgical options, whatever makes sense for your life, for your family, and for what you would think makes sense for your health too. So that's prolapse. And any questions about prolapse in general before we kind of go on?
I have a question. Can you hear me?
Yep, Judith, I can hear you. Please go ahead. Yep.
Great. I have actually two questions. I'd love you to put your diagram back and show us where the pelvic floor is. What is the pelvic floor?
Definitely.
And how does pelvic floor exercises differ from the Kegel exercises, which I am doing right now as we speak?
Yes. So the pelvic floor is actually everything that surrounds the vagina. So this is the vagina right here. The pelvic floor would be, so these in between this tan area are muscles. And there's multiple different sets of muscles, over 7 of them that support the vagina, the urethra and bladder, and the rectum. So this whole area here is the pelvic floor. As you're doing a Kegel, and what a Kegel is contracting these muscles here around the vagina. So if you were able to put a finger in the vagina, you would feel the vagina actually tighten during a Kegel exercise. But doing a Kegel appropriately also means that your abdomen is not contracting down either. So you're not using your muscles here in the abdominal wall, and that your rectum back here, your buttocks are not contracting too. I would say most of us are doing Kegels wrong. I was doing Kegels wrong before I went to a pelvic floor physical therapist. So essentially almost everything we're going to talk about, I've gone and done because I want to know what my patients go through. So I've gone to a pelvic floor physical therapist, had them do exercises with me to kind of see what's going on. I am a urogynecologist and I was doing Kegels incorrectly. Most of my patients are doing Kegels incorrectly because most of them use the muscles in their abdominal wall. So watch yourself do a Kegel right now. If everyone can try, do a Kegel where you're trying to contract the base of the pelvis by kind of, as if you're trying to hold gas in or hold, not go to the bathroom. When you do that, a lot of us also contract our muscles here on the abdomen too. So pelvic floor physical therapy teaches you how to do a Kegel correctly, but also teaches you other exercises too. They teach you how to relax the pelvic floor. They do something called diaphragmatic breathing, which actually is core exercises to actually strengthen your core too. Because although I want to strengthen this area as much as possible, at the same time, none of these muscles work by themselves. So then understanding how the rest of the body here works too, and doing exercises for that actually helps both prolapse as well as incontinence too. Did that answer your question, Judith?
Yes, thank you so much, because well, if you try to hold your bowel in, would that be different from a Kegel?
No, it should be very similar. It's essentially, I feel like a motion that's going upward, as if there's a suction cup in your vagina going upwards. That's kind of what you should be feeling.
Okay, thank you.
You're welcome.
I have a question, please.
Yes, Barbara.
I do have a prolapse, and my doctor has not advised me to have surgery, but just manage it. But once you have a prolapse, can you ever reverse it with exercises and PT? Or
Yeah.
are you just trying to prevent it from getting worse?
So both of those things, yes. PT and doing Kegels can definitely prevent it from getting worse. If you have mild prolapse, it can actually decrease a prolapse by about 1 centimeter. So, for patients who have very, let's say this whole area from here to here is 8 centimeters, and that's what it is on average. If you only have a little bit, the physical therapy, going to a good physical therapist can definitely decrease the amount of prolapse you have by 1 centimeter. So it goes up a little bit. But if you have, 8 centimeters of prolapse, that's going to be a bigger ordeal.
Right.
And physical therapy may not be ideal for that. But yes, it can definitely reverse it if you have mild prolapse.
And then I was wondering, do you feel there's any benefit to virtual PT? Because some people don't want to go right now due to COVID.
Yeah, I would say majority of physical therapy offices are doing virtual PT right now. And I've spoken to a number of them to try and figure out what they're doing exactly. And there is benefit, especially compared to doing nothing or doing something incorrectly, right? And so virtual PT, I think, still has good benefit. Obviously, being there in person and doing a physical exam with you and kind of going through it is the gold standard, and that's what we would love. But right now, with being safe and social distancing, virtual PT I think makes sense.
Thank you.
Welcome.
I have a question. My name is Judy.
Yes, Judy. What can I do for you?
And so I was diagnosed quite a while ago with prolapse, and I was getting ready. I'd even scheduled an appointment to have surgery. And then there was all this stuff in the paper about mesh. And so I hope, can you talk to that? Because I found myself saying something to the surgeon like, oh, what about all these problems? They said, no, don't worry. So again, the options, it sounds like with the surgery is either entering vaginally and there's no mesh, or using mesh. So could you explain it? It just, feels like none of the doctors have ever recognized why I'm concerned about mesh. Thank you.
We can definitely talk about it. I actually have a long conversation about mesh with all my patients if we decide to use it. But so there's different kinds of mesh, and that's, I think, the most important part of this. So what Judy's talking about is when we talk about surgery for prolapse, there's different types of routes as well as different types of techniques. So the vaginal surgery, which is probably what I offer the most often for my patients does not utilize any mesh. It's your native, it's just your tissue with sutures that dissolve over time. So nothing foreign will be in your body after 8 weeks or so. The mesh that's out there that you see a lot of those commercials for and the litigation for, and that's in the news, is vaginal mesh. And that's something I've never used. And there's different reasons why it is in the news, but essentially there were some complications that arose from it. And a lot of providers walked away from it. And thankfully so. There's no reason to actually utilize vaginal mesh or prolapse from what we see in the studies now. So long-term studies have shown us that we don't actually need to do that, and we're okay not doing that too. So you don't have to have mesh for surgery if you don't want to. Doesn't have to be a part of your treatment options if that's something you're very much so against. So that goes for vaginal surgery for prolapse. There's also abdominal surgery that we talked about, right? And that's when I make small incisions on the abdomen, all like small and essentially the size of my pinky. And what we do there is essentially, that's more so for women who have a lot more severe prolapse. And we're thinking they're also very, very active too, meaning they're the ones who puts the kayak on their shoulder as they're going kayaking as well. So for women who have severe prolapse, who are very active and very healthy, the thought is the vaginal surgery, although that works rather well, it doesn't work quite as well as the abdominal surgery that incorporates mesh. This mesh has not been a part of that, that huge litigation that's out there. That was all vaginal mesh. This mesh is FDA approved, and it's the same type of mesh that people use for hernia surgery. So general surgeons have been using that for years and years. It's also different from when these lawsuits started. These lawsuits started about 2011, a little bit before that as well. That type of mesh was a very heavy weight as well as tough mesh. This is ultra lightweight mesh that we use abdominally. The other thing is, since we use it in the abdomen, we often leave the cervix in place. And the whole idea with mesh, when we think about complications, what we're thinking about is that the mesh at some point might go through the vaginal wall and you might see it in the vagina. And that might cause bleeding, irritation. Most patients don't actually notice it's happening at all, but it could be an issue for them. So if we leave the cervix here, it's another barrier so that the mesh actually doesn't get to the vagina. So chances of mesh erosion with keeping the cervix in place and putting it in through the abdomen are about 5% or a little bit less than that. So it's not incredibly high, but there is a chance of it. And the only times I actually advise someone to use mesh is if they tell me, I want to go after this and, do all the things I did when I was 40 years old. I want to be able to lift just as heavy things, or, I'm a farmer. I have to lift. My day-to-day life has to continue in this way. And so for them, I say, hey, rather than doing a vaginal surgery that although works for most women, let me give you the strongest type of repair because you're going to test this every day for the next 10, 20 years. And I want to make sure you don't have to come back to the operating room again. So that's essentially mesh. If we do a vaginal route, you're not using it. If we do an abdominal route, we are. And then the mesh now is different from the mesh we've used in the past. It's still a conversation. There are some risks, but they're not incredibly high.
Is this all done in the office or in the hospital?
So surgery is all done in the hospital, but other treatment like the pessary, pelvic floor physical therapy, all that stuff's done in the office.
I have a question. My name is Rita. I have tried to do Kegel exercises, and even just doing one makes me sore. So I start older now, but I tried doing it when I was younger with the same results. And I have both urinary and fecal incontinence.
So, that's really important. So one, it could be, you might not be doing the Kegel exercises correctly. Two, you might be doing them correctly, and that's how your body responds to it. And if that's true, then what else can we do for you to help you with your urinary and fecal incontinence? Because there are other options, and I'll talk more about that as we go on with the presentation for urinary incontinence as well as fecal incontinence too.
Okay, thank you.
Welcome. Yeah. Any other questions about prolapse?
Yes, doctor, are you willing to recommend therapists?
Yeah, I can actually send a list of therapists. The one thing is that pelvic floor physical therapy often needs a referral. So you'll need a prescription as well. But really, if you see a general gynecologist, they can give you the prescription. A urogynecologist like myself can as well. Even your internal medicine doctor can. But yeah, I can send you guys a list of providers after this session that you can have that if you are going to internal med doctor, a gynecologist, or if you want to come to one of us, we can always give you the referral and then you can give them a call as well.
Thank you.
Any other questions?
I have a question.
Yes, Stella.
I do have the sling inside already, but now I can't control it at all. I'm having trouble even using the Kegel, doing the Kegel. What can you do for a person like me who's older and has lost control where I
So I think you're talking more so about urinary incontinence.
a little louder?
I think you're talking more so about urinary incontinence, right? Leaking.
Urinary incontinence, yes.
Yes, so we'll talk all about that right now. So I'll start that whole portion.
Okay, very good. Thank
So that was prolapse. That's probably half of what I deal with in a given day. The other half is incontinence. And incontinence is essentially not being able to control your bladder, right? Continence, most of us would love to have the ability to know when we're going to go to the bathroom, time that at a time that's socially acceptable for us too, right? However, 1 out of 3 women, we don't have continence. We leak at different degrees and different severity. So there's 3 different types. There's one type called stress, and that's when you leak when you laugh, cough, and sneeze. There's another type called urge. That's when you leak when you get the strong urge to go to the bathroom, but you just don't make it in time. And then most women actually have a combination. So they have a mixed urinary incontinence picture where they have both stress and urge. Oh, okay. Let's talk about treatment options actually right now. So the reason why it's important to figure out whether you have stress or urge incontinence is because treatment for each one of these is different. So I believe, we just heard about someone having a sling. So they probably had what we call stress urinary incontinence. So that's leaking when you laugh, cough, sneeze, picking something heavy up. That happens because the muscles aren't strong enough anymore. And the urethra now, whenever there's pressure up here from the bladder, whenever you laugh, cough, sneeze, the urethra can't close, and now you leak urine. So we have to do something to make the urethra stronger. One of those things is pelvic floor physical therapy, right? The Kegels that we talked about before. We can use a pessary again here too. What the pessary does is it sits in the vagina right underneath the urethra. Whenever you laugh, cough, and sneeze, there's pressure on the urethra so you don't leak. The other option is surgery. And surgery is that sling where it's a hammock that we put right underneath the urethra. So then when you laugh, cough, and sneeze, the hammock activates upwards and you don't leak. All of those options only work for stress urinary incontinence. Okay, so that only works when you leak, when you laugh, cough, sneeze, lift something heavy. A sling will not help your incontinence if you're leaking when you get the urge to go to the bathroom and you're just not making it in time. So many of us start out in life with having stress urinary incontinence. That's what we have after having pregnancies, childbirth, whatever it may be. So at the age of 30, a lot of us start having this leaking where we're like, if I laugh really hard, I'll have a little bit of leakage. And that gets worse as the years progress. However, later on is when urge urinary incontinence comes into play. So although we start with stress, and that one is because the muscles are weak, later on our bladder stops working quite as well, and we start feeling this urge to go to the bathroom, have to go to the bathroom multiple times a day, and then sometimes can't make it in time to the bathroom itself. Urge is different. Urge is not because of the muscles being weak, and so the treatment for that is not a pessary and it's not surgery. The treatment for this is medications, really. So we start with one conservative management. Actually, we talk about what fluids you're taking in, how much fluid. There are some things called bladder irritants, which are caffeine, artificial sweeteners, carbonated beverages, and alcohol that make your bladder start acting up a little bit more so. We teach you how to do something called bladder training. If those things don't work, then we talk about medications. These medications make it so that your bladder doesn't contract quite as often. So you're not running to the bathroom quite as often, but you're also not leaking quite as often too. If medications don't work, and there's a number of different types, then there's also different other treatments. There's something called PTNS, which is essentially acupuncture in the lower leg that we do in the office for patients. It is successful for about half of our patients. We do Botox injections in the bladder, just like we do Botox injections in the wrinkles stop contracting. The same thing goes for Botox injections in the bladder. We can do that either in the office or the operating room. And there's even more treatment. You know, I tell you about all the treatments in the beginning just to let you know that, hey, if one doesn't work, that doesn't mean nothing's going to work. There are other things. So the person who just asked me about, hey, I had a sling in the past. You had that sling for your stress urinary incontinence. But now it sounds like you probably have some urge incontinence too, where you have no control and you leak all the time. So now what I would say is see a doctor about that, because the treatment strategies for that are very different from the stress. And it could start by just changing what you're taking in terms of your fluid intake. It can then proceed to medication management or even acupuncture or Botox injections. So that's urinary incontinence. There are patients who have urgency, frequency, where they go to the bathroom very often. They have that urge to go to the bathroom all the time. They start waking up in the middle of the night to void multiple times at night, and they never feel like they're emptying their bladder completely. And this all goes on, but they're not having leaking of urine. It could lead to leaking of urine, but some women don't have that leaking. And that's okay too. That's what we call overactive bladder. And the treatment for that is actually the same as the urge incontinence that I talked about here. Talk about what you're taking in terms of your fluids, figure out what makes sense in terms of your diet. And then if those things aren't working, talk about something called bladder training, where we slowly make the capacity of your bladder bigger. If that doesn't work, we talk about medication management too. So the most healthy bladder habits, the things to do regardless of whether or not you have these issues, even if you don't have overactive bladder or urinary incontinence, the following things make sense for all of us. And will make it so that we don't start getting these issues in the future. So number one, limiting our bladder irritants. So that means that cup of coffee we take in the morning. How many of you take that cup of coffee and then you know you're running to the bathroom afterwards for the rest of the morning? Caffeine is the number one bladder irritant. Caffeine also brings a lot of joy to our lives too. So it becomes an issue of figuring out how much caffeine, if at all, and whether that's more important to you than having to run to the bathroom or leaking urine as well. Other bladder irritants are carbonated beverages. So anything with bubbles, anything with fizzies, right? So the sodas, the seltzers, all of those things will cause our bladder to start contracting a bit too much. Artificial sweeteners, so those are all the fake sugars that are out there, and alcohol as well. The other big thing is making sure our fluid intake is between 48 to 64 ounces. So that's about 6 cups of water, right? And I don't mean the glasses of water, cups, 8-ounce cups of water. That should be your total fluid intake for the whole day. So that includes your juice, your tea, your coffee, your alcohol, everything. A lot of us feel as though that we have to drink more and more and more to be healthy. That's a myth. We don't know how much you really need, but we do know that more than 6 to 8 glasses doesn't really do much of anything for us. The other thing is something called bladder training. And that's a technique that we teach you in the office. It takes a little bit more time to figure out how to increase the capacity of your bladder so that you're going to the bathroom every 3 to 4 hours. That's your goal, rather than going to the bathroom every 30 minutes to an hour. And then physical therapy, strengthening the muscles in the vagina along with Kegels always helps out too. So those are all of our bladder issues. Any questions about that?
What about,
have
I'm sorry,
coffee?
may I ask? You just talked about the liquid. What about the diet? What about the food which can provoke this frequent?
Yeah, so number one is liquids, mostly because that's what comes into the bladder more so and contacts the walls of the bladder. And so those are the irritants. But yes, there are some patients who even outside of the liquids they take, If they're eating acidic foods, that can increase their bladder overactivity. So acidic foods can be anything from tomatoes to citrus and all those other things. I am very careful to not start on that route first. It's really important to start with these 4 things initially, because these are our number, our 4 heavy hitters. If we start talking about all the things that are in a diet, it could be your whole diet, really. And those may not even be what's actually causing this to happen for you. And I would be very sad to limit what most of us already have a limited diet to begin with. But yes, it is something to talk about, especially with your provider. If you say, hey, these 4 things are not it, and I've been doing the other treatment and the other treatments are not working for me, maybe it's something in my diet, and then we can go over that as well too.
I have a
Thank you.
question. I took medication for overactive bladder for a few years and it stopped working.
Yep. And that can happen to about 10 to 20% of patients. And so sometimes it works really well for a few years, and then sometimes it stops working for them. And so even if that medication stops working, it doesn't mean that there aren't other medications that may work for you. Oftentimes I try at least 2 medications, and if they don't work, then I move on to the acupuncture or the Botox or something else that can work for the overactive bladder. The other aspect is, if you don't want to try medication, you just jump to the acupuncture, because the acupuncture really has, no side effects. The only thing that's difficult right now is that it's weekly treatment. So it's something you have to come to the office weekly for right now. You can always do that as well too. But yes, if the medication didn't work for you after a few years, I would talk to my provider about maybe changing to a different medication. And if that doesn't work, the other treatment options we talked about.
I tried to. I really like acupuncture, but insurance does not cover.
No, so we do this acupuncture. So it's not going to an acupuncturist.
Yeah.
So even though I call it acupuncture, it's a little bit more than that. There's a dry needle that goes in, but it's actually connected to a stimulator as well, electronic stimulator that we do. And so actually insurance and Medicare covers that for our patients. So, but it just has to be done by a medical provider. That's usually a gynecologist or a urogynecologist. So it actually insurance will cover it.
What is your opinion about the surgery for incontinence?
Yeah, so if you have, the kind of incontinence where you laugh, cough, and sneeze when you leak, that sling surgery is one of my favorite procedures, because most of my patients, when they're in the post-op unit, just an hour after surgery, they're better. The effectiveness is about 92%. It's anywhere between 90 to 94%. So having a treatment option that's over 90% successful as a doctor is something I love to have, to say that, hey, I can give you this. And over 94% of women are really happy at the end of this.
Does it still involve the kind of batteries, but you need to be replaced from time to time?
No. So it's actually a hammock that we put into the underneath the vagina, under where the urethra lays. So that's the type of incontinence where you laugh, cough, and sneeze. If you're talking about the surgery for the type of incontinence where you have the urge,
yes,
that's called a neurostimulator. And yes, every 7 years that battery has to be changed or so.
I have
Thank
a
you.
question.
Go ahead.
I really like coffee, but I have to say it does bother me, particularly if I have 2 cups of coffee. Can you suggest an alternative? Like, would decaf be okay, or is there something?
Yes. So that's what I often suggest. And the other thing is, I tell people not to do cold turkey. Going from 2 cups of coffee to nothing tomorrow, or going to decaf tomorrow, you're going to get a headache. You're going to feel miserable. You're going to miss your coffee. And then 2 days later, you're going to be back on, right? So I say, yes, rather than going from 2 cups to nothing, go from 2 cups of coffee today. And tomorrow do 1 cup regular and the other cup half calf, or it's half caffeinated, half decaf. And then do that for a week. Then the next week, do 1 cup regular coffee, the next cup, all decaf. And then the next week, make it so that your first cup is half calf as well. So that slowly over time, you're decreasing your caffeine. but so you're not getting, all of these side effects during this time too. Decaf is a-okay. Decaf is wonderful. Going for both coffee as well as tea.
Okay.
What about cocoa?
So cocoa has some caffeine, but not nearly the same amount as coffee and tea. So a cup of coffee, like a small cup, has usually about 50 to 80 milligrams of coffee. Cocoa probably has about 5 to 10. So it's, coffee is almost 10 times more potent than cocoa. So having, a little bit of cocoa here and there should not be, as long as you're not drinking, 8 glasses of cocoa a day.
I have a question.
Yep, Rita.
Okay, the artificial sweeteners, I've cut out all the other things.
Yep.
But why does the artificial sweeteners, why is it an irritant?
Yeah, so the way that those sugars are made up, since they're not real sugar, they have a different type of structure. And that type of structure actually binds to the inside of the lining of the bladder and causes the bladder to start to contract because it just doesn't like it.
And the acupuncture, I have moved recently. I had a doctor who gave me the acupuncture and it worked, but I can't find anybody. I live in the Bronx.
Yeah,
Could
so
you give me a referral?
definitely. I think so myself as well as all my partners do it. So at the end of this talk, I can send the last slide is our phone number and our office address and everything. So it can all be there. You can just make an appointment and we can always start up again where you left off with the acupuncture.
Okay, thank you.
You're welcome. Any other questions about bladder concerns?
Is there any difference between these artificial sweeteners? Because I don't take sugars. And what kind is it, Splenda or whatever,
Exactly.
aspartame? Which one is better? Which one is worse? Could you tell?
So they haven't done the studies of which one's better or worse. They just know that all of them have some sort of bladder irritant effect.
I see.
Yeah.
About stevia drops.
Included stevia, Truvia, Splenda, all of them.
Well, it's the pure stevia, so-called pure stevia drops.
Yeah,
So-called.
Exactly. I mean, it's just one of those things where, although pure, it's artificially pure.
Okay, I got it. I can't see what the ingredients. I need a magnifying glass. I'll look after.
What about aspartame? Is it the same?
Yeah, aspartame is a part of it as well too. Yeah. And so the thing is, an irritant is not an irritant for everyone. Caffeine is definitely an irritant for most of us.
Yeah, we learn it. We learn in a hard way.
Yeah. So the only way to figure out whether or not artificial sweeteners is an irritant for you is you can take it out for a day or two, see if it helps your bladder symptoms. If it does, great. Then that means that probably that artificial sweetener is what's causing this. If it doesn't, you put it back into your diet, right? I'm not someone to come here and tell you, take everything out of your diet that could possibly cause you some harm, because at the end of the day, it's probably doing some benefit for you too. So it's important to figure out if it actually is. So take it out, see what happens after a few days. If it's not helping your bladder symptoms, put it back in. Any other questions?
Yeah, I have another question.
Yeah,
When I'm emptying my bladder, a lot of times I have to wait, and then there'll be more. And, I don't know when I'm finished sometimes.
Yeah. So that I call that double voiding. And a lot of people do that. And sometimes you actually have to stand up and get back and sit back down on the commode and empty again. Number one, not everyone empties their bladder completely. And usually that's okay, as long as it's only a small amount left in your bladder afterwards. If it's large amounts of urine that's left in your bladder, then yes, I want you to double void to make sure you empty your bladder more so. If it's small amounts, continuing to do that is going to make it so that your bladder feels smaller and smaller and smaller. And you'll feel like there's something in your bladder, even though it's very little and you don't have to actually empty at that point. So a little bit of double voiding is okay if you have large volumes on your second void, but if it's less than half a cup of urine on that second void, that's okay. All of us have some fluid left in our bladder after we try to void. Any other questions about the bladder?
I have a question, sorry, that's in the chat. So I'll read it.
Thank you.
How often do vaginal surgeries need to be repeated? That's the first question.
Yeah, so vaginal surgeries, depending for if it's on for prolapse, they're anywhere between, depending on the type of surgery, 70 to 95% effective. So depending on the type of surgery, you may not never need it again. Some surgeries have, you know, I kind of say it depends on how old you are, how much you're going to be lifting afterwards, based on whether or not the prolapse comes back. Prolapse surgery to me is kind of like plastic surgery. Imagine someone at the age of 50 getting a facelift, right? Doesn't mean at the age of 65, you're not going to have some drooping occur again because gravity happens again. Same thing for prolapse surgery. If you have it done when you're younger, if you're going to be lifting a lot of stuff for the next 10 years, that prolapse might come back. And if it does, then you might need surgery again. The chances of that are still low. It's about 10 to 15% of women. So very low, but still it's an entity out there. And what was the second question?
The second question is anything we can do to try to avoid UTIs?
Yes. So to try to avoid UTIs, there's a bunch of different things. Number one is how do you void and how do you wipe? If you wipe from back to front, you increase your chance of UTI. So always wiping from front to back. 2, wearing cotton underwear is probably the best thing you can do, avoiding any type of synthetic materials. 3, making sure that your vaginal health is healthy as well. And we do that with something called vaginal estrogen, which I'll talk about more so as the presentation goes on too. 4, to decrease your chance of UTIs as well, there's different types of medications that are very much so like supplements. So it's different types of things that can combine cranberry extract along with vitamin C, along with some other kind of defenses that make it so that your bladder is less likely to have a urinary tract infection. But if you're having more than 3 in a year, or if they're getting severe, I say go talk to your doctor and we make a very tailored plan of what we do for you. You don't even have to come to the office oftentimes for that. We can do that for a telehealth appointment. A lot of my urinary tract infection patients, we do via telehealth to kind of figure out a plan initially. Any other questions?
I don't see anything.
Okay, so I'm going to briefly go over fecal incontinence. Fecal incontinence is similar to bladder incontinence, whereas rather than having accidental leakage of urine, now you have accidental leakage of either, fecal matter, so actual bowel movements, or loss of gas too. This could be either loss of gas, like I said, solid fecal matter, or liquid stool. As we age, it increases the chance of this happening. And fecal incontinence occurs anywhere between 2 to 25% of women, depending on what other medical issues they have as well. So it's something that most of us don't ever talk about, but a lot of people, including people I'm sure in this talk that are hearing me speak right now, are experiencing. Risk factors. Smoking and obesity, both of those things increases our chance of getting fecal incontinence. Medical issues that are any type of neurologic issue or diabetes increases our chances. And then there's different people who have different types of inflammatory bowel diseases like Crohn's and ulcerative colitis. That will make it more likely for you to have fecal incontinence. If you're more prone to diarrhea in general and have loose and watery stools, it's going to be harder for your body to make sure that you don't actually lose the control to release that stool too, because what our body is used to is solid bowel movements. When you make that loose or watery, the body doesn't know how to react to that. And sometimes you might have fecal incontinence, but more so just because you have diarrhea. Different types of lacerations and things that happen during vaginal deliveries, including episiotomy or forceps, things like that, can increase our chance of fecal incontinence as well, because it decreases the muscle strength within the pelvis, and then prior surgeries too. Treatments. So here, this is where conservative therapy is the #1 thing, okay? We start really kind of analyzing exactly what you're eating in a given day, how much caffeine and fiber you're taking in, when you do have your bowel movements, how are you having a bowel movement? Are you sitting in an appropriate position or not? Once we actually figure out what your day-to-day life is like, then we can make recommendations in terms of what to do for your food and beverage intake, what to do for your caffeine and fiber intake, when to time your bowel movements, and how to sit to have one as well. Then we talk about different types of skincare things to do. You know, making sure you have soft toilet paper, washing around the anus rather than using a lot of paper products, avoiding any products with perfume or our dyes, and wearing cotton underwear as well. And if these things don't work out, then we start talking about medications, things that can either bulk your stool so you're not having diarrhea quite as often, antidiarrheals as well, and then different types of prescription medication too. So that's fecal incontinence. Any questions there? Those are our conservative managements. There are more invasive therapy as well that includes surgery, but we always start here. And if this doesn't work, we go on to pelvic floor physical therapy with something called biofeedback. So it's a very specific type of physical therapy that you have to go to a colorectal to do. And if that doesn't work, then we start talking about surgical options as well. Any questions about fecal incontinence? I know we went kind of fast, just want to make sure that we kind of go over all the things that we have left. Okay, so now we'll talk about the vagina itself and just a healthy vagina. So after menopause and also actually after childbirth too, we start having vaginal dryness. And some of us can have burning sensation in the vagina or even pain. And that pain can be with intercourse or it can be just even without doing anything as well. This can be because of lack of lubrication, can lead to impaired function. And oftentimes we start having recurrent urinary tract infections because of all these things too. What's happening is our estrogen levels have decreased. And as our estrogen levels decrease, the walls of the vagina get thinner. Rather than having thick vaginal walls with multiple levels of cells, that gets thinner and thinner and thinner because our estrogen levels are thinner or less in the vagina. As that happens with a thinner vagina, think about any place in your body that has thin tissue, right? If I try to scratch my forearm, it doesn't hurt that much. But if I scratch the skin right at my wrist, where my skin is the thinnest, I feel it more. It's more irritating. It also can get dry a lot faster too. So with that, the same thing happens in the vagina. As the tissue gets thinner, you'll feel more dryness, have less lubrication, more burning sensation, and at times, more chances of getting a urinary tract infection because there are also estrogen receptors in the urethra. And now bacteria that lives normally in the vagina can jump up into the urethra, into the bladder more often. This can have different signs for different women. Some women have just those sensations we talked about just in terms of the symptoms. And some women actually see something physically where they see cracks on the outside portion of the vagina and they have decreased secretions and lubrication as well. So what do we do for it? So there's both medical management that we can do with prescriptions and then things that we can do without prescriptions. So if you're just having some vaginal dryness that's occurring every once in a while, or if you only feel it during intercourse, and you're like, hey, otherwise, this doesn't bother me, and I'm not getting urinary tract infections either, then we talk about over-the-counter lubricants. There's things called slippery stuff, which is probably one of our favorites. There's Astroglide, there's KY jelly. All of these are safe to use, don't increase your chance of infection, and essentially make it so that while you're having any type of vaginal intercourse, it's not going to hurt quite as much. But it's a short-term fix. It only helps during that episode itself. If you're having chronic vaginal dryness as opposed to intermittent, where it's happening every day, then we start talking about long-term relief things. So there's both non-prescription and prescription. So now we're talking about vaginal moisturizers rather than lubricants, right? A lubricant only helps with putting something externally during that second, making it so that it's smooth during that second, that's it. Now we want the vagina to be moisturized because Now we're feeling this dryness every day. And if we are, these are the things that are vaginal moisturizers that you can get over the counter that will help. You have to use these regularly. It's not like the KY jelly from the last page where you're only using it during intercourse. This is something you're using weekly so that the vagina starts creating its own moisture. The different things are Replens, KY long lasting, and KY liquid beads. These are the three, and Replens is definitely my favorite in terms of maintaining hydration for the vagina long-term when you don't want a prescription. This is just for dryness, okay? This is not for patients who have the dryness, the burning, and the urinary tract infections. If that's happening, then we start talking about vaginal estrogen. That is very different from oral estrogen. So it's not the hormone replacement therapy you've all heard about and people have talked a lot about. This is just estrogen that's given either as a tablet, cream, or ring that we put in the vagina. So it's only absorbed in the vagina. The amount that gets into your bloodstream, into the whole body is so, so low that it's as if it's not even there. So we don't have the same side effects that we talk about with oral estrogen. Plus, this helps out with increasing lubrication, decreases vaginal dryness, decreases your chance of getting urinary tract infections, as well as different urinary symptoms like urgency and frequency too. If you just heard me say a lot of positive things, it's because I love vaginal estrogen. It's one of my favorite medications. It's one of those things that helps so many of my patients. The one thing about it though is it takes weeks for it to start working. Okay, so if you start it today, if you call me next week, it's not going to work. It's going to maybe start working a little bit, but it takes about 6 to 8 weeks for it to slowly rebuild the walls of the vagina to make it healthy again. So it takes about 6 to 8 weeks for you to actually start getting really good results. Any questions about vaginal health? All right, well, thank you for having me talk today. We kind of went over a few different things. The prolapse and incontinence is definitely the bulk of what we do. So that's definitely where the bulk of your questions are too, and what most women kind of go through in their day-to-day life. The other things with recurrent UTIs, vaginal dryness, fecal incontinence, definitely is still something that we feel great about treating. So if those are issues for you guys as well, feel free to reach out. If you have questions regarding your very specific condition, you can do a telehealth or a new patient visit. This is our phone number. It's 212-305-1107. These are our main office locations on 4th Washington Ave, right next to Columbia main campus. We have an office in Westchester too, in Orangeburg, another one on 51st Street in Manhattan, another one in Scarsdale. And depending on where you live, what's most convenient for you, you can come see us from whatever office you'd like if you want an appointment. Otherwise, things that are very simple too, and just in the beginning of all of this, your gynecologist can also help you out too, or have them refer them over to us as well.
You working in the department of OBGYN department or urology? Which one? I cannot hear.
OBGYN department.
Oh, thank you.
You're welcome, Galina.
Can you give us some recommendations for the physical therapy?
Yeah, I have a huge list and it all depends on where you live. So I'm going to send that to Margie. So then she can kind of put that out there for you. But once again, you'll need a referral. Otherwise, it gets rather expensive. So I'd always kind of go the referral route first. It doesn't matter who gives you that referral. It could be your gynecologist, it could be us. But I'll give you the list. I'll send the list as an email so that Margie has it.
Any other questions?
Yeah, hi. I don't have a question, I have a comment. My name's Iris. I'm a retired RN PA. This was a wonderful presentation.
Thank you.
And I really learned from you and also from my fellow participants, asked some good questions that answered some of my questions too. It was a really good presentation, very understandable and good.
To agree with you, it was excellent.
I have, there was one other question. Do you treat patients from out of state?
Yeah, we do.
I'm sorry, can you repeat what you said, Doctor?
Yes, we do. We do treat patients from out of state.
Correct me if I am wrong. Do I need to refer from my OBGYN doctor to you, my physician, or I can make just appointment? With
No,
you?
you can make an appointment yourself. Your OBGYN is more than happy to refer. If they're not, you could always just call the number and you can do a self-referral too. Insurance usually covers it too.
Thank you.
Okay, last chance for questions. Obviously, if something comes up, I have the doctor's email and we can certainly send her a note, and she's extremely responsive. She looks like a great doctor to have, like she'll really talk to you. Anything else?
No, we just all want.
Wait a second, wait, I'm sorry, Galina. Marianne, did you have your hand raised? You have to unmute yourself or put the question in chat. Just someone's coming to unmute you. Okay, go ahead.
Can you?
Unmuted?
Yeah. Can you hear me?
Yes, we can.
Oh, okay. Just a question. Can scoliosis cause urinary incontinence?
So it depends on if the nerves are being impinged from the scoliosis. So usually urinary incontinence isn't the only issue you would have. So you would have some other things going on as well, probably decreased sensation in your fingers and toes. And different types of feeling, like a burning sensation sometimes. So if you're having nerve impingement from the scoliosis, then yes. If you're not having nerve impingement, then the urinary incontinence, it's so common, it can happen just by itself too.
Okay, all right, thank you.
You're welcome.
Anything else? 1, 2.
I just want to say thank you.
We all want to thank you very much.
Well, thank you guys. What makes a presentation, easy and good is when people actually talk to me, so having the questions, and thank you so much for trusting us all and sharing, because that's when we all learn the most. So thank you so much, everyone.
I'm sorry, we have one more question in the chat and I just lost it. Hold on a second, I got to pull it up again. What is it when you have fecal leakage after a bowel movement?
Yeah, so that's called fecal staining. And it could be either because you have fecal incontinence, or it could be because you have hemorrhoids, and the hemorrhoids are making it so that you're just having some staining occur. Either one of those things we could see you for, but actually probably a colorectal would be the best person to kind of give you some headway there. Dr. Lee Kong, Lee space Kong, is my favorite colorectal at Columbia. But if you're going to go to other places, any colorectal would be more than happy to help with that, because I'm guessing more often than not that's probably a hemorrhoid that's going on.
As I'd like to talk about the acupuncture part.
Yes,
could that be done at White Plains Road in Scarsdale? It would be just in the office.
Definitely,
Okay.
yeah. And Dr. Lozo is the one who really goes to that office more often than not. So she's wonderful, and she'll do a great job with acupuncture for you.
How do you her name? Lozo?
Lozo. Yep. And if you call this number right here, the 212-305-1107, yeah, you'll get all of us. So, and
yes, I've had a lot of work done at Phelps Hospital, but of course with pandemic, everything has stopped. But this would be much closer for me.
Yeah,
okay, well, I'm so glad you put this on. It's been a big problem, and I thank you very much.
You're welcome.
Well, I think what's great about it is it's something that we, I think as the doctor said, we don't talk about a lot. So I wasn't sure how many people, to be honest, would even register for it, because I thought people want to talk about it. So this is, been lovely, and maybe we'll do a follow-up.
Wonderful. No, one time we didn't talk about it, but now we talk about it. those of us that have the problem. Thank you so much.
Really helps.
Now it's the brain that has so much to do with it, because just talking about having to go, all this, I have to go. So I know that's
a big part. So that's the bladder training portion. And that's another big thing that we talk about in the office, and figure out how to do bladder training so that the brain controls the bladder rather than the bladder controlling the brain.
Thank you so much.
Thank you very much.
Thank you.
Okay, I am going to, unless there's anything else, and we're going to close it down. Thank the doctor again. We will have a video of the presentation to share with you guys, and we'll send it to the doctor as well. And I think that's it. Yes.
Wonderful.
Thank you, everyone. Have a good,
Thank you.
hopefully it'll be a more peaceful day today than yesterday. So everyone have a good day.
All
Okay.
right.
Thank you very
That's good.
much.
Thank you. Thank you again, doctor.
You're welcome.
Thank you.
Take
Thank
care.
you. Wow. All right.